Forward to the last presentation of this session, and I have the pleasure to announce my colleague from the CHUV, Professor Laurent Nicod, who is the head of the Department of Lung Disease. And it's a pleasure to have you here, Laurent. Merci beaucoup. Alors,
thank you.
On est curieux.
I don't know if you leave me 5 minutes or if I may have a little bit longer. What I will try to do in these few minutes is perhaps not mostly see the treatment, but the prevention, which has changed, which is changing these days in concept. So I won't go into these details of the background, how the exacerbation does occur, but it's important to remember that not only bacteria, viruses and pollution are important factors to induce airway inflammation, bronchoconstriction on one hand, and systemic inflammation with the cardiovascular effect that you have heard about. So we know that exacerbation lead to decrease in lung function and long-term increased mortality, increased economic cost, and decreased quality of life. And you can see that not only the GOLD 3 and 4 with a moderate or severe obstruction do have exacerbation, but also already at GOLD 2 you can see that a few patients will be hospitalized, and 39% will have at least one exacerbation per year, which is a huge burden. And the differential diagnosis, you heard a lot about it, so I won't get into the details of the arrhythmia, right heart failure, pulmonary embolism, and so on. But remember that drugs can also lead to hypoventilation, and tranquilizer and hypnotics should be looked for. When you have an exacerbation, the patient is disabled for more than 2 weeks. Indeed, the symptoms are related, are reported at least 2 weeks, but you see that some patients remain housebound for quite a long time. The prescription of prednisone have been well established in this key paper in 2008, in 2003. You see that you have more probability to remain recidivity free in the next 30 days if you are given prednisone. In this study, it was 40 milligrams for 10 days. In Basel, they repeated the study where they gave only 5 days instead of 14 days the systemic steroids, and they had a similar outcome for the short course of steroid with a 65% reduction in steroid, a short length of stay, 8 versus 9, and no increase in recurrence of exacerbation or mortality. So you can, depending on the patient, do a short trial of steroid. As far as concerned now exacerbation, people try to do cluster analysis of what are these exacerbation. Are they more related to bacterial infection, more related to viral infection, or eosinophil, or some cases are called post-inflammatory. And here is also a new trend to try to understand what is the role of the microbiota. You know that our lungs were described as sterile till lately, but now we know that we have a mixture of germs. Some are anti-inflammatory, some are inflammatory. And those who you know are leading to exacerbation are all related to this phylogenesis with Enterobacter, Haemophilus, Moraxella, Pseudomonas, and some others that are less common. Now, who to treat? We have to go back to this Antonisen paper, who remains true despite all the study which have been done since then. If you have 3 major symptoms like dyspnea, increased PUTA, purulence PUTA, these patients clearly benefit from antibiotics, and they have a shorter exacerbation. so that the guidelines, which will be renewed soon, and Thomas Welte on Friday will discuss probably on this, because he is the leader of the next guideline for antibiotic treatment in lung disease. The fact is we do not need to use antibiotics for those patients who have got only one antinisant criteria. On the opposite, for those who have got 2 or 3 symptoms from antinisant, and they are elderly, they have poor lung function, used to have exacerbation, or have cardiac disease, these should be treated with a more extended coverage of their disease, and you have to be careful if they have been hospitalized in the last 3 months to look at alternative class and do a culture. Of course, you will have to reassess the patient after 72 hours and advise your treatment according to the culture you will have. Here is a paper which is pretty recent, where they used antibiotics with amoxicillin and clavulanate or placebo, and you can see that you delay the re-exacerbation rate. The one who received antibiotics had 233 relapse rate free, and for those who received placebo, they had only 166 days before they relapse into the disease. Most of these patients had type 2 and type 3 antinisant score. You see that the patients who have got Pseudomonas are very special, and you need to be careful about them, even if the evidence in the literature is not very strong. But you see that this patient had been visiting their practitioner for 9 visits, and they were decreasing their lung function by 104 milliliters of their FEV1, and a quality of life which was really poor. After inhalation of colistin twice a day, their FEV1 decline per year was decreased by half, and their quality of life increased by 2. So this is Pseudomonas are really bacteria which is leading to much more morbidity than other colonization. Now the frequency of the exacerbation, if you have more than 3 exacerbations per year, you see that your probability to die is much higher than if you have only no exacerbation in the last year. So these exacerbations are really important. So from what the COPD are dying, the lung remains the major cause in the TORCH study. Cardiovascular is the second with 27, and tumor is frequent in this patient, much more frequent than in the rest of the population of smoker without COPD. You see that the more exacerbation you do, the more chance you have to do a myocardial infarction, and you heard a lot about it. But if you have an ischemic heart disease, you can see that most of these patients will have an increase in their troponin during their exacerbation related to those who do not have an ischemic heart disease. The same is true from proBNP, which is clearly enhanced in the patient who has got coronary heart disease. Now, if you are a frequent exacerbator, are you going to remain a frequent exacerbator? This study looked at the patient first year, classified the patient in frequent exacerbation or exacerbator or infrequent exacerbator. And the second year, they watch again their patient, and they saw that about 40% of the frequent exacerbation could move to the infrequent exacerbator. So it's not that you are going to be stuck on this aspect. And if you are an infrequent exacerbator, 20% will go to the frequent exacerbator type phenotype. And what the predictor was the presence of systemic inflammatory product like CRP, fibrinogen, or chemokine. And the patient who switched from frequent to infrequent exacerbator had the lowest level of these different markers. And now this is another study looking at CRP, white blood cells, and fibrinogen. And you see that the patient who had all three markers which were elevated had an odds ratio to do exacerbation, which was 6-fold higher than those who had none of these elevated inflammatory marker. Now, what are we giving to this patient to prevent exacerbation? Most of us are giving inhaled steroids combined with a bronchodilator. Is it right? First, is it efficient? The TORCH study did show that if you give a combination of fluticasone and salmeterol, you have a better outcome of this patient with an improved FEV1, and you have a decreased rate of exacerbation if you have, again, this combined treatment. But lately, this concept has been challenged because first, the more you give steroids, inhaled steroids, the more chance you have to develop pneumonia by reducing lung defense. And you see that if you give more than 1,000 micrograms per day of fluticasone, you can go up to more than 2 times higher rate of pneumonia. So that people are interested more and more these days to look at regime steroids free. And here you see that it was a good surprise lately to see that if you give tiotropium, LAMA, and all of that to combine, you had a much better outcome on as far as concerned the FEV1. It was unexpected that COPD could improve so much their lung function by combining these two substances. And now coming on the market, several combination of these long-acting beta-agonists and muscarinic antagonists. Is it important? Yes, because we see that this combination of treatment, the LAMA and LABA, reduce further the rate of exacerbation, much more than tiotropium or glycopyrronium used alone. And this study, which just was presented last month at the ATS and published in the New England at the same time, did show that you have an advantage to give LABA and LAMA without steroids compared to salmeterol and fluticasone. Indeed, even for moderate or even for severe COPD, giving the salmeterol and fluticasone with the steroids content, there was an enhanced rate of exacerbation. And in addition, if you compare the advantage of giving LABA and inhaled corticosteroids, lung function with time is less advantageous than if you give adacaterol and glycopyrronium, for instance, a LAMA and a LABA combined. And this is really consistent and impressive. Now people have started to lately stop the inhaled corticosteroids given to their COPD. What is it going to do? In fact, removing inhaled corticosteroid taken overall in this big cohort of wisdom had no impact on the exacerbation rate. The only thing that it did is some patients did lose a little bit of their FEV1 by removing the inhaled corticosteroids. Who were these patients? These patients were people with more than 300 eosinophil per microliters. You see here they had a clear benefit to remain on inhaled corticosteroids. And this is important because it's going to perhaps change our practice. So that you see that that is the combined assessment of the COPD and how we try to organize our treatment according to the classification of airflow limitation with the GOLD classification from 1 to 4 according to the symptoms and according to the exacerbation rate. And you can see that these patients have good lung function, pour little in the way of exacerbation, whereas the patients who are in this area have got many exacerbation, poor quality of life, and are with a decreased lung function. And the treatment we give to the first one are rather LAMA alone or LABA alone. Sometimes you can combine them. And for classically, the one who have got the more severe disease were receiving inhaled corticosteroids, LAMA and LABA. And now the new concept, which is not yet published but is coming probably soon, is that the patient who have got more than 300 microliters eosinophil per microliter, or asthma, COPD, overlap syndrome, a COPD with a clear asthma component, should receive these inhaled corticosteroid, but the other one should receive only LAMA and LABA. What about the other substance capable to decrease exacerbation? You have the roflumilast, azithromycin, and N-acetylcysteine. The roflumilast has been a little bit deceiving and is efficient mostly in patients with chronic bronchitis, but not with patients having emphysema. The azithromycin has two major studies now have shown a clear advantage to provide azithromycin to the frequent exacerbator. And you see that the odd ratio to develop an exacerbation is decreased nearly by 2 if you give azithromycin at the dose of 500 milligrams 3 times per week. We tend to give it in our clinic half of it, and it works very well. As far as concerned N-acetylcysteine, it is still controversial. With some study we did show no advantage. Now 2 recent studies coming from Japan using high dose of N-acetylcysteine twice a day do show an advantage and a reduced exacerbation rate. As far as concerned vaccination, I won't insist, but you know that it decreased clearly during the the period of influenza, the rate of exacerbation compared to those who are not vaccinated. And exercise, we will have a session and even several communication during this meeting on the role of exercise to improve quality of life and decrease exacerbation rate, and it's pretty important. So that, in conclusion, COPD exacerbation lead to a decline in lung function, enhanced morbidity and mortality, cardiovascular, as you heard several times, being frontline. Short course of oral steroids decrease the length of exacerbation and their recurrence. Antibiotics given for purine secretion decrease the length of COPD exacerbation and their recurrence. Long-lasting anticholinergic and beta agonists have a marked additive bronchodilatory effect and reduce the rate of exacerbation. Inhaled steroids should be restricted to asthma COPD overlap syndrome or to COPD with eosinophilic component. The roflumilast, azithromycin, and readaptation are something which is useful for those patients who are really frequent exacerbator. I thank you for your attention.